My name is Ron Aaron Eisenberg. I am delighted to serve as the MC for a program that will begin not only today, but run through May and all of June, every Saturday. For the Global Pain Association, we take a look at chronic pain, ways in which it can be addressed, ways in which those who suffer from chronic pain can find relief. Loved ones and others who are living with someone struggling with chronic pain can understand the mechanism and perhaps join in finding solutions that are not necessarily drug related. We talk about all the different types of chronic pain that's out there, and we talk about the kind of impact that stress in the middle of COVID-19, for example, the coronavirus sweeping across this country can cause to people and their families who are struggling with chronic pain. Well, it is a pleasure to kick off this series with the young woman who had the brilliant idea of doing this, who is the co-founder of the Chronic Pain Association. And it's a real welcome to Susan Blackwood. Dr. Blackwood is formerly the head of San Antonio Sports. She was the one who brought the women and men's Final Four to San Antonio and has been instrumental in dealing with athletes at the college and the professional level. And she understands, as a result, the kind of chronic pain that people, for example, who are athletes go through. So Susan will give us an overview of why a Global Pain Association. Susan, thanks for joining us.
Well, Ron, thank you so much for hosting this. The Eisenberg Group has done a brilliant job of putting this series together for us. We had hoped to have a seminar on May 9th, inviting all of our chronic pain followers in San Antonio and their caregivers to an event that we were going to have at the Omni. And as a result of us being involved in the pandemic, we certainly, our hats go off to you and your bride, Gina, that have put this together for us. We have a volunteer board of 10 people that have done a tremendous job in the last year and a half of putting an organization together and showing people how passionate and how caring we are in terms of trying to find a resource for people with chronic pain and their caregivers. And as a result of our event last year, in 2019, we see the success that this organization can bring and the help it can bring to people that need this kind of resource. So again, thank you for hosting this, and we're really excited about having the second week of the program.
Share with us, if you got a couple of moments, on why a chronic pain association, the Global Pain Association, and what you hope happens.
Well, certainly we want to introduce alternative ways that people can manage their pain. And this series is a perfect example of 8 weeks of having opportunities to introduce strategies and therapies and things that people can rely on to help reduce the anxiety, the loneliness, the toil on their families, their finances when they are chronic pain sufferers.
And for folks who want to get involved, both perhaps a member of the Global Pain Association, maybe they want to support us financially, how do they do that?
Well, all of our events are free for the chronic pain patients and their caregivers, and that has been a philosophy of ours since day one. But if people want to donate, I think we've got a crawler across the screen showing them how they can go to globalpain.org, get involved and donate. And we're looking for sponsors for this series. We had 18 sponsors at our September event in 2019, and they certainly saw the advantage of reaching and being able to connect with people with chronic pain, since they have devices and services and support that help chronic pain patients.
Well, Susan, I know that there are literally hundreds of thousands of people who can be helped by the Global Pain Association. So we thank you for forming it. We're going to move you to the background until the end of the program and bring in our very special guest, who is our speaker for today, Dr. Pendleton Wickersham, who is an expert in dealing with pain. He himself has been a chronic pain sufferer, and he can talk about that as well. Dr. Wickersham earned his medical degree with honors from Baylor College of Medicine in Houston, board certified in internal medicine and rheumatology, partner in the San Antonio-based Arthritis Associates. He consults and speaks before a whole lot of groups on pain and talks too about several medical devices that he has invented as a way to deal with chronic pain that people suffer. Texas Monthly Super Doc named him in 2015 as a super doc here in the state of Texas. And as an original board member of the Global Pain Association, we're delighted to welcome him on board. Dr. Wickersham, want to remind folks before we bring you on that this educational series is free, open to everybody who wants to participate. And this pain education series presented by the Global Pain Association, we're here every Saturday at noon in May and in June. And if folks want to learn more about it, just go to info@globalpain.org. So Dr. Wickersham, welcome. We're going to get your mic turned down and we'll try that again. Nice.
All right, sure.
There you are. Nice to see you.
All right, now I'm here. So I just wanted to say thanks, Ron. I'm really excited about the seminar today, about the opportunity to talk specifically about some myths surrounding chronic pain. So we'll get to that in a little bit here. So
I mentioned that you suffer chronic pain, and I'm assuming that's part of the reason as a physician you've gotten involved in it. Tell us a little bit about yourself, if you don't mind.
Sure. So I was in medical school and fell in love, did a rheumatology elective, fell in love with rheumatology because of many factors, especially the long-term relationships I saw between doctors and patients. And on my rheumatology rotation, what had been sort of an intermittent problem flared up. I had a massive flare, in fact, and was having difficulty walking. And it turned out that my professor at the time was one of the world experts in the arthritis that I have. So you can call it serendipity, you can call it blind luck, but it pushed me further into rheumatology for sure.
And what is the arthritis you have?
So I have ankylosing spondylitis, which is historically thought to be mostly an arthritis of men that affects the low back. It turns out that it's almost gender neutral. It's almost as common in women as it is in men. And the prevalence, depending upon what study you look at, is almost 1% in our community. So this is an example of back pain that for many, many years, lots of people who've struggled haven't been properly diagnosed. So this is just one of many types of arthritis that can cause chronic pain that need further evaluation.
In fact, I was going to ask you, there's no one arthritis.
Oh, goodness, no. You know, we in the medical school, we always made a list of everything, right? So we had to learn a list of the different causes of X or Y. But there was the list of different types, different causes of arthritis, and it's over 100 long, which is really striking if you think about it. So,
and it is not age specific?
Absolutely not. So arthritis, and specifically the wear and tear form of arthritis, which affects more than 30 million people in the U.S., osteoarthritis, that is more common with age and, of course, with injury as well. But in general, arthritis can happen from a very young age. Juvenile rheumatoid, or now juvenile idiopathic arthritis, as it's called, can happen in a toddler. So it can happen at any age and any stage in life.
Now, I know you were kind enough to prepare a presentation for our Global Pain Association viewers for today's program. And if you're ready, we're ready. We're going to turn the stage over to you.
All right, let's get started. Thanks, Ron. Well, welcome, everybody. This is quite a pleasure for me to be able to talk about some of the myths surrounding chronic pain. You know, part of what I do as a rheumatologist is I see people in pain because I see arthritis. And so this is a topic that's very near and dear to my heart. So before we talk specifically about the myths, I wanted to define chronic pain for everybody. What truly is chronic pain? And the answer depends upon who you ask. So basically, it's pain that doesn't go away. And that seemed pretty self-evident and straightforward. In the medical literature, there are all sorts of criteria and cutoffs. It's got to last for 3 months. It's got to last for 6 months, a whole year. And I wouldn't get too caught up in that. The best definition actually that I've seen is from the textbook shown here: pain that extends beyond the expected period of healing. Next slide. So I'm going to give you 6 myths here that I'd like to try to debunk about chronic pain. And we'll start with myth number 1, that normal aging causes pain. I can't tell you the number of people I've seen over the years who have come in, they've been struggling with pain for 2, 3, 4, 5 more years. And I say, well, you know, why didn't you come in and get this checked? Do you have arthritis? And they say, well, I just figured I was getting older. But being a few decades past 20 doesn't guarantee pain to anyone. Pain always means something is wrong. Yes, it's true certain types of arthritis are more common with age and more common with injury, but don't mistake aging for pain. What does that mean? Chronic pain always deserves an evaluation, if for no other reason than to just have some management of the pain, of course, but also because there are many underlying causes that can be treated independently of actually just addressing the pain itself. Next slide. Myth number 2 here, and this is one of my particular pet peeves. It's grin and bear it. So in our society in the U.S., we're always prone to think what doesn't kill us makes us stronger. But when it comes to pain, putting up with it actually can make us worse. There are some consequences which are really interesting in the nervous system of persistent pain. The first has to do with neuroplasticity, the brain's ability to adapt. And we call this central sensitization. And the idea here is that our nervous system adapts to whatever we do. So if you go and you spend 6 months reading and studying and memorizing, over that period, you're going to get better at your short-term memory. That's adaptation of the brain. That's a wonderful thing. But with chronic pain, if you spend that same 6 months struggling in pain, unfortunately, the spinal cord, the brain get really better at signaling and processing pain. So the pain actually increases over time. Another effect we look at is wind up. And the way to think about this is that pain adds. And so think about this. So if you smash your thumb with a hammer, you get an immediate, sudden, terrible pain. That goes away pretty quickly, but then your thumb's going to ache for a while. Well, if you do something else, such as stub your toe while your thumb is still aching, instead of being a separate pain, it adds on top of the thumb pain. And if you have a third pain, it adds on top of that. With chronic pain, people who are struggling every day and having pain all of the time, the pain seems to accumulate and stack up and add. And we call that wind up. So what does that mean? Well, that means that it's important to seek out treatment, because not getting treatment means you're probably going to get worse over time. There are some other effects of pain on mood and sleep. One of the interesting things about how pain affects mood is that it's not just about suffering, which is a huge factor in mood, and poor sleep, which is a huge factor in mood and how it affects people's ability to do things, to spend time with their families, to enjoy things. What also happens is the same nerves that bring pain signals from the body to the brain, they go to the surface of the brain, tell you where you're hurting. My toe's hurting today, my ankle's hurting today, my knee's hurting. But they also go deeper into the fundamental primitive brain, some of the mood centers. So there is a direct connection between that pain signaling and your mood. And so that's yet another reason not to grin and bear it, to address the pain. Next slide. Next slide, please. Here we go. So myth number 3, medications are bad. And this may seem an odd topic to bring up for the Global Pain Association, where our real emphasis is to stay away from some of the more powerful medications such as narcotics and to look at other treatments. But the truth is, a comprehensive approach is important. There are 3 fundamental basic types of medications that are used for pain. The first are anti-inflammatories like ibuprofen and naproxen. There are also neuropathic pain treatments that work on that central sensitization I was talking about earlier, and examples, among others, are duloxetine, gabapentin, pregabalin. There are narcotics as well, but there's some problems with each of these. Each of these classes and the individual medications themselves have potential side effects. There's also a lot of concern about addiction. Narcotics are heavily regulated right now. There's even stigma. And so what I'm not suggesting here is that everybody take all these medications. What I'm suggesting is that it's very important to have a provider, a doctor, a PA, a nurse practitioner with whom you have a close relationship, a trusting relationship, who will listen to you so you can sit and have a discussion about the risks, the merits, the benefits, what could go wrong about medications, because they often are an important part of the treatment plan, but only if you understand and watch for problems as well. Next slide. So we're about halfway through here. So we've got 3 more myths here. So y'all bear with me. So myth number 4, exercise makes pain worse. And I hear this all the time in my practice. And sure enough, if you have chronic pain, chances are, unless you work at it, you've really gradually cut back on your activity level. So that means the loss of muscle, loss of endurance. And then if you go and do something, you're going to be in bed for 1, 2, 3 days recovering. And that is absolutely the case. But exercise, in one study published late last year, showed significant benefit for people with pain. So 5 days at least of exercise, 5 days per week, dramatically reduced pain. 3 or 4 days didn't, which is kind of interesting. It had to be a pretty consistent exercise. So where's the disconnect here? How do people get to the point of exercise? And the answer is it's got to be gradual. So I'm talking about very low impact exercise. Water therapy is probably the easiest on the body because of the buoyancy of the water and how it takes a lot of pressure off the joints. But it can be the exercise bike or walking around the block or some gentle yoga or Pilates. But it's got to be gradual. Many of my patients have to start with just a simple 5 minutes of exercise each day until they get used to that, and then go up to 7 minutes, and then gradually build up over a period of many months to ideally 30 or 40 minutes a day. But the key is not to push it past that point of where they've actually trained to, right? So don't push it too hard, because overactivity, as I said before, often does cause worsening. Next slide. So myth 5 is that everybody feels pain the same. And the truth is, pain is different for everybody. And part of that is because of how it affects our social lives and our interactions with our families and our mood. But pain processing itself is different. There are some really interesting functional MRI studies in fibromyalgia, for example, which is a classic chronic pain syndrome. And what these researchers did in this one particular study I'm referencing is they put a thumb screw, basically squeezed the thumb of people with fibromyalgia, and then people who didn't have fibromyalgia, so-called normal controls. And what they found is if they squeezed the people with fibromyalgia's thumbs just gently, they had pain. And they had to squeeze the normal controls thumbs really hard to get that same level of pain. Well, that's not surprising. People with fibromyalgia are more sensitive to pain, and that's just part of the disease itself. What's interesting is the functional MRI component. So functional MRI is a way to image the brain while things are happening and see what areas are activated, what areas light up. And what's really striking about this study is that super hard squeeze on the normal controls and the gentle squeeze on fibromyalgia led to identical brain activity. So what does that tell you? That tells you, first of all, that people with fibromyalgia have real pain because their brains are interpreting it absolutely as such. But it also tells you that everybody processes and interprets pain differently. Next slide. All right, we got the last slide here, and this is probably what we should end with. Improvement is not possible, and that's absolutely a myth. But it is very important to manage expectations for everybody involved, because right now, with our current sophistication in dealing with chronic pain, the treatment is management instead of a cure. Part of that is because the central sensitization that happens, the brain changes over time, so the pain is not likely to be zero no matter what anybody does. I try to tell my patients if their pain is 9 out of 10, if we can get them down to 5 out of 10, their quality of life, their ability to do things, to enjoy themselves is going to be a lot better. So it's important to understand what's realistic. I think it's also important to look at this from a comprehensive perspective. So I encourage people to come at the problem from every direction possible. So of course that means medical interventions when needed. That means exercise, which we talked about. It means alternative therapies, and you're going to hear in the rest of this series about a fair number of alternative therapies that can be of benefit. I showed a picture here of acupuncture, which is just one of those therapies that often helps. And then finally, addressing mental health aspects of pain too. So if people want to do the best they possibly can, they need to do as many different things to address the pain in as many ways as possible. And that's all I have. I'll be happy to take some questions now. Back to you, Ron.
For you, and one that I think is one of the more interesting that kicks it off. You talked about nerves and detecting pain, but what is pain? How are we actually feeling pain?
But, I mean, so pain is a wonderfully adaptive protective mechanism, right? If you grab a hot plate on the stove, you want to let go as quickly as possible to minimize how badly you burn your hand. So pain is really useful and important. If you have something going wrong, like an appendicitis, that pain is a huge danger signal to your body. You need to do something about this. Unfortunately, with chronic pain, the signal takes on a life of its own. And so even if you take away whatever triggered it to begin with, a lot of times that signal persists in the brain and in the spinal cord.
Now, I know that people who have problems with their feet, who may have diabetes, who get to a point where they don't feel pain in their feet, doing the same thing that someone else would feel pain. Is there a way to translate that into reducing pain for people who are feeling it?
Well, it's a really interesting concept, right? Because I think I can remember a patient I had who had pretty severe gout, which is one of the most painful things known to man. And as his diabetes worsened and his nerve damage worsened, he couldn't actually feel how bad the gout was. The problem is, if you lose all that sensation, you also lose all the protective aspects, which is why, one of the reasons anyway, that people with diabetes and nerve damage get ulcers on their feet, because if they get a little cut, they can't feel it. So yes, there's a lot of research looking at ways to interrupt some of the pain aspect of the signaling, but you can't block it all the way because there's some utility there too.
That gets to my other follow-up question that
Sure.
one of our listeners had written in. Can't you just cut that nerve from the place the pain is coming from?
And you absolutely could, but you'll lose, first of all sensation, because nerves travel in bundles, and so they'll be pretty damaging, I think. But the other issue is, because of that adaptation of the body, a lot of times the pain signaling will still happen. And so one example of this is in people who have an injury and develop chronic pain and end up having an amputation. They will still feel the pain in that limb that's not there anymore. So they can have their leg cut off and they can still feel pain in their leg because the nerves remember it and they're still signaling, which is really quite disturbing, right?
Well, one of the sad statistics, San Antonio leads the nation in foot and below the knee amputations, often almost totally type 2 diabetes related.
Right. Absolutely.
I have a friend who went through that. He talks about that so-called phantom pain. It may be phantom, but it hurts.
It's very real, because one of the important points here is that if your brain tells you you're in pain, you're in pain. It's a real phenomenon. And so I think we kind of struggle with that, and this is a very extreme example where you don't have the limb anymore and yet you're still hurting. But in general, we kind of struggle with, is pain real? Well, as I told you in the functional MRI study with fibromyalgia, the signaling is the same in the brain as if you didn't have any problem and you had a major injury. So that pain is absolutely real.
Now, we've gotten several questions along the same line, and that deals with the issue of, are there ways to identify pain, categorize it for the pain sufferer to self-diagnose, figure out what's going on?
Well, sure. And there's some broad classes of pain. So, so if a pain is localized and sharp, it's different from that a dull type pain. In particular, the development of pain over time, where you get the change in the brain, so the so-called neuropathic pain, that often has a burning or tingling or numbing or stabbing sensation with it. So you can kind of look at that. However, chronic pain always deserves an evaluation, partially because it needs to be treated, but partially because there are often underlying processes that are fixable, right? And I know if somebody has a bad knee, maybe they need a knee replacement. Now, I will tell you that about 25% of people who have a knee replacement still have some pain afterwards in the knee, even though the original knee structure is not there. And that just goes to tell you what the nerves can do over time and that same signaling issue. But certain causes of pain are actually fixable. So I would highly recommend people get a comprehensive evaluation to make sure there's not an underlying issue that we can fix.
Now, you and I have talked about it. I had left knee total replacement.
Mm-hmm.
The moment I woke up from surgery, the pain was gone. I was literally living on ibuprofen until that surgery. And since then, I don't think I've had one. It's been over 2 years now. That's a pretty good thing.
That's wonderful, right? And for 75% of people who have it, that ends up being the response. I will say that the average person who has a knee replacement has a lot of pain during the recovery period. And so most of my patients aren't really happy they did it for up to 6 months, but then they're very happy, right, after that. So you had a particularly good response, and good for you.
Talk to me a little bit about what loved ones and caregivers can do to work with and help people with chronic pain. You know, we live in a world in which 65 million people are caregivers. That number will only go up as society ages. What can caregivers do to help a chronic pain sufferer?
Well, I think one of the most important things is that the pain sufferer just wants support, right? They Nobody can understand pain unless they've lived it. So I don't think it's reasonable to expect caregivers, loved ones, to completely understand what they're going through. And that's not necessarily what people want, but they really just want a support and an ear to listen. And I will tell you that with chronic pain, which is day in, day out suffering, there is a lot of caregiver fatigue that comes with it, right? People get tired of hearing about the pain when they're caring for their loved ones. But really what people with chronic pain want is support.
And relief.
Well, of course, right? But of course, but the loved ones, what they can do is just be supportive and be loving. Frankly.
Now, for those of you who may join us, you're listening to the Global Pain Association's first weekly series on pain. We will come to you with this virtual symposium in which we have a guest speaker or two, look at an issue involving pain. It's free, open to the public. And Dr. Wickersham, you've had the honor of being our very first. Got one last question for you.
Sure.
How do you find a doctor to treat the pain you have?
And that's a great question, especially in today's day and age when there's so much regulation of pain medication and so many providers are afraid of prescribing anything for pain. And fortunately, the world has changed. And so we have reviews, right? And yes, there are always reviews that are perhaps not as accurate, but in general, reviews are a great way to see if somebody's going to listen to you. Because I'll tell you, when it comes to pain, having a doctor, nurse practitioner, PA who will sit and listen to you and really try to understand what's going on and help is the most important factor.
Well, I want to thank you again for coming on. We truly appreciate your time and information that you have provided. And for folks who want to see this again, this presentation will be available at the Global Pain Association Facebook page, and no cost. You can share it with friends and neighbors and take a look at it again. So, Dr. Wickersham, thank you. Appreciate it.
Thanks very much.
We're going to jump now to Dr. Susan Blackwood, who is one of the founders and a founding board member and president of the Global Pain Association. And Susan, as you listen to this very first of our programs, what do you think?
Well, first of all, I want to thank Dr. Wickersham for his time and efforts. He is a valuable board member to Global Pain Association, and his guidance has really gotten us to this point where we're really reaching so many people in our community. I am really excited that he talked a lot about the myth about exercise, because next week we have Dr. Nydia Darby and Dr. Terry Bogus talking about the importance of exercise for chronic pain patients. And of course, Nydia is the world's best at explaining how yoga can be involved in the healing process. So we're really excited. And thanks for that lead in, Dr. Wickersham. But Ron, I want to thank you again for, again, being an awesome host and moderator. And we couldn't do this without the Eisenberg Group. So thank you again for your time and efforts.
We appreciate it. And why don't we do it again next Saturday, 9 or 10 or 11 or 12? How many we have coming? Every Saturday for the rest of May and June, beginning at noon Central Daylight Savings Time. And if you want to find out more about the Global Pain Association, just go to globalpain.org and you can find out everything you need to know and a whole lot more. And Susan, you can always use funding to make these programs possible.
Absolutely. We encourage people to donate. Obviously, there's no requirement. We want to offer our services and efforts free of charge to our chronic pain sufferers in the community. And South Texas, we've really reached out to a lot of people through these virtual series. We also have sponsors that sponsored our clinic last year, which was in September, and we're hoping that they'll come back and help us with this virtual series, because there's a lot more people that we're reaching through this mechanism.
And so once again, join us again next Saturday, for whatever the date is, next Saturday, and we learn all about exercise, yoga, and a whole lot more.
May
Susan Blackwood,
16th May
go ahead.
16th at noon. We'll see
Perfect,
you out
thank you.
Mhm.
We'll do it again soon. And to Dr. Wickersham, thank you very much. Have a great day, everybody. Global Pain Association comes back next week, right here on Facebook.